Hello, I'm Dr. Kimberly Ford. On behalf of CME Outfitters, I'd like to welcome you and thank you for joining us for part 3 of a 3-part CMEO Pharmacist Central educational series entitled Beyond the Prescription Refill, the Role of Pharmacists in Ongoing Monitoring of Patients with Hepatitis B. The CMEO Pharmacist Central series is supported by an educational grant from Gilead Sciences. As I mentioned, I'm Kimberly Ford. I'm a hepatologist, associate professor of medicine in the section of hepatology, Department of Medicine, at Temple University Hospital at the Lewis Katz School of Medicine in Philadelphia, Pennsylvania. I'm very happy to welcome Dr. Lauren Heinecke to the program today. Dr. Heinecke is an associate professor of pharmacology at the University of Maryland School of Pharmacy in Baltimore, Maryland. Welcome, Lauren.
Thanks so much, Dr. Ford. I'm excited to be here with you today and talking about this very important topic.
First, I'd like to go over our learning objective for part 3 of this series, and that is to use interactions during hepatitis B medication refills to counsel patients about routine monitoring for hepatocellular carcinoma and hepatitis B reactivation. So Lauren, let's start with an overview of hepatocellular carcinoma. HCC is a primary liver cancer and a dreaded complication of chronic liver disease. It has the 8th highest mortality rate among all cancers. And to put this into perspective, its 5-year survival is approximately 18%. It's important to note that the incidence and mortality for other cancers has been decreasing while we see a continued increase in HCC, an increase that was approximately 38% over the period of 2003 through 2012, and that increase was driven by viral hepatitis. It's also important to recognize that there are differences between hepatocellular carcinoma that arises in the setting of chronic hepatitis C infection and that which we see in chronic hepatitis B infection. So for hepatitis B, there is a risk of HCC even in the absence of cirrhosis. Hepatitis B is a carcinogen, and it increases the risk of HCC by 50 to 100 times, while hepatitis C increases that risk by approximately 15 to 20 times. These distinct differences in epidemiology of HCC and chronic hepatitis B infection have important implications for making decisions about who to screen and when to screen. And many of the society guidelines that are in place, including that from the AASLD, specify the performance of surveillance for HCC in patients with chronic hepatitis B infection without cirrhosis, with cirrhosis, and also with a history of HCC. We're going to address some of this more specifically in the talk. Lauren, would you like to take us through a review of risk factors for hepatitis B associated HCC?
There's really 3 big buckets that these factors can be placed in. The first being host factors. So family history of liver cancer increases the risk for the development of liver cancer in patients infected with hepatitis B. We certainly know that older age, as people are aging, we see a higher rate of liver cancer developing in hepatitis B infected patients. Male sex is a risk factor for progression to liver cancer. There certainly are genetic and ethnicity factors that we're going to go into greater detail in a little bit. And then this next bullet is including diabetes and obesity. So really, with the development of metabolic syndrome and the obesity epidemic in the United States, there's been a higher rate of non-alcoholic fatty liver disease developing. And so having that disease state on top of the hepatitis B virus increases the risk of developing liver cancer. And then cirrhosis also would increase the rate of hepatocellular carcinoma. And in the last slide, you heard that patients with hepatitis B can develop liver cancer even in the absence of cirrhosis. But it's important to note that about 70 to 90% of those with cirrhosis and hepatitis B infection are going on to develop liver cancer. So there is a very high rate of progression in our cirrhotic patients. There are also environmental factors. This is our second bucket. So we know that smoking can increase the risk of developing liver cancer, as well as alcohol use. And certainly we know that alcohol is a hepatotoxin as well. So you're having two hepatotoxins, that would really increase the risk of liver cancer. Now, this last bullet, aflatoxin exposure, you may have never heard of this before. So this is pretty interesting, but aflatoxin is actually a hepatocarcinogen, and it's produced by Aspergillus species and is frequently found in undercooked food. So I think in our first module, we talked about the importance of fully cooking food, and it's really because of this hepatotoxin development in undercooked food that is the reason for that. There are also viral factors specific to the virus itself. So hepatitis B virus can integrate itself into the host DNA, and that itself can increase the risk for the development of liver cancer. And when they've looked at specific genetic sequences, they've found that the specific cancer sequence has been in close proximity to that hepatitis B integration into the host DNA. There's also factors related to virally translated proteins. Important to note, too, that in hepatitis B virus, there are at least 10 different genotypes that have been identified. So I think a lot of times we talk about genotype with hepatitis C, but not as frequently with hepatitis B. And so specifically genotype C has been implicated as having a higher rate of developing liver cancer. We know that co-infection with other viruses, including viral hepatitis C, HIV, and hepatitis D, increases the rate of the development of liver cancer, as well as late antigen loss. And then finally, other factors include persistent elevation of liver function tests. So this is looking at really your ALT value, and when it's greater than 1.5 times the upper limit of normal, this can be associated with an increased rate of development of liver cancer or hepatocellular carcinoma. So that was a whole lot of risk factors, and probably really important to drill down on, I think, the racial and ethnic disparities. So Kim, I'm wondering, are there racial and ethnic disparities that we should be aware of related to the development of hepatocellular carcinoma?
Lauren, that's a really great question. So there are certainly racial and ethnic disparities. You also talked a little bit about some of the sex differences as well. This data comes from a study conducted by Salvatore and colleagues. They looked at liver cancer incidence rates from 1992 through 2016 in the SEER database, and they made some really important observations. And so liver cancer incidence was higher in men, and you talked about perhaps sex hormones influencing that incidence rate. Interestingly enough, the rate for men has plateaued. The rate in women continues to increase. And so we should think about that when we're thinking about, high incidence risk groups and who to screen, certainly. Rates tend to be low in whites, while much higher in other racial and ethnic groups. So highest in Asian and Pacific Islanders. Again, this rate was seen to have peaked in this particular group. The incidence was also quite high for American Indians and Native Alaskans. So again, I think that, this incidence data speaks to the need to screen, and particularly which groups may have increased risk of the incidence of HCC. So Lauren, what are some of the symptoms of HCCs that, pharmacists should be aware of in their patients?
So remembering that where the liver is located, I think, is the first thing to kind of start out with, to kind of put this into perspective. So it's in the upper right quadrant. So these first symptoms that you're kind of seeing, so right side upper abdomen discomfort, A lot of times when people complain about, and I always say quadrant because that's how they present when we're on medical rounds, but when they present about right upper abdomen discomfort, a lot of times people are thinking, oh, it's something going on in the liver. So that specific location for the discomfort can give you a clue that it's something related to the liver, not always liver cancer, but it could, that's probably the big thing that you'd want to rule out when someone's complaining of right side upper abdomen discomfort. People may have a swollen abdomen, and that can be associated with hepatocellular carcinoma. So important to note that these things are not going to give you the exact diagnosis, but definitely are things that make you think, is there something going on with the liver that would prompt additional studies and really would make you think about telling them to go see their primary care doctor if they're not already established with a hepatologist. Patients may complain about a hard lump on the right side below their rib cage. That could be a symptom of hepatocellular carcinoma, or pain near the right shoulder blade or back. So probably many of you are familiar with jaundice or the yellowing of the skin. You know, I always think it's important to talk about scleral icterus too. I feel like that's the first place people notice a yellowing. So it's a yellowing or a discoloration of the white portion of the eyes. A few last things to talk about. So easy bruising or bleeding. And I think that this really drives home some of the things we talked about in module 1. A lot of this easy bruising and bleeding comes from a decrease in platelet count that we see in patients who have really advanced liver disease. They also might complain of unusual tiredness. Of course, this is going to be very non-specific, so I'm not sure you're going to jump straight to liver cancer or liver problems just with unusual tiredness, but along with some of these other things might lead you to think about a liver issue. Nausea and vomiting, again, kind of like unusual tiredness, one of those sort of non-specific things that we can see with so many different things. So probably looking at that in conjunction with some of these other ones. The loss of appetite and weight loss for no known reason, I think, are associated with many types of cancer. And oftentimes, to better assess this, one of my favorite things to ask my patients when they complain about weight loss is I ask about their pants and if their pants are fitting differently. And I also ask about belts, if they wear a belt and they've had to purchase a new belt or notice that they're using a different hole in the belt than they previously used, just to get a better sense as to the degree of weight loss that we're potentially talking about. So those are some of those big signs and symptoms. Kim, did you want to add, you look like you want to add something into the discussion.
I was just gonna, to your point about weight loss, you know, certainly it could be associated with many things. As patients with decompensated liver disease continue to progress, you can certainly see weight loss, and in particular, some component of muscle wasting. But certainly when a patient comes to the office and they tell me, you know, their clothes are baggy, they've had to change the size of the clothing that they're wearing, they haven't been intentionally trying to lose weight, I am certainly worried that an underlying malignancy is what we're dealing with. And I have to tell you, for the liver patients, it doesn't matter for me whether I've just screened them 3 months prior for HCC. It's something that I'm going to look for again. I'm very concerned when they come to the office with this complaint.
Do you have a sense as to the how quickly patients may complain about this weight loss? Is it over a particular period of time that you're looking for?
Sure. I would say that the recommendations that are currently in place for surveillance for HCC are timed out at 6-month intervals, and that's based on the potential doubling time of the tumor. But again, certainly I think even if you have thought about surveillance for HCC, you're up to date, and a patient comes in 2, 3, 4 months later with this complaint, I think it's worthwhile readdressing the issue.
Now it's really important to jump into talking about who's indicated for surveillance as it relates to HCC or liver cancer. So certainly in our discussion, we've already talked about patients with cirrhosis are really at increased risk for the development of HCC. So all people with cirrhosis, including people who seroconvert or have hepatitis B, but basically lose that hepatitis B surface antigen. So they become hepatitis B surface antigen negative. So they've had that seroconversion. They still need to be screened for hepatocellular carcinoma if they've already developed cirrhosis. And then you've already heard that hepatitis B really increases the rate of development of hepatocellular carcinoma, even in the absence of cirrhosis. So there are some specific recommendations for screening in people who have not yet developed cirrhosis, but who we know are at increased risk for developing liver cancer. So Asian or Black males who are over 40 years of age should be screened for liver cancer. Asian females older than 50 years of age should also be screened for liver cancer. People who have a family history of hepatocellular carcinoma, so we've heard that that family history is an important risk factor that we should be considering. And then finally, people with hepatitis D virus co-infection should also be screened because of the increased rates of hepatocellular carcinoma. So we now have an understanding about who we're screening, but many pharmacists probably are not terribly familiar with exactly what surveillance methods are used and even the frequency that these surveillance methods should be done in these patients. So Kim, would you be able to tell us a little bit more about the surveillance methods that are used and the frequency with which they should be done?
Absolutely. So it's recommended that patients at risk for HCC, as you outlined in the prior slide with hepatitis B infection, undergo a surveillance method. What is recommended is an abdominal ultrasound with or without alpha-fetoprotein every 6 months. For me, when I was doing my training, I used abdominal ultrasound and AFP, and I still continue to do that. I think that, many times you can pick up an elevated AFP, and that is of concern, and that prompts me to get additional imaging, and we'll talk about that in a minute. But I do think that there is some information that can be obtained from following that alpha-fetoprotein, and so I certainly continue to do that in my clinical practice. An MRI with and without contrast or a CT scan, that is a triple phase CT scan, is needed for the evaluation of suspicious lesions or, as I noted, if the AFP is elevated. It's important to note that hepatocellular carcinoma is one of really a handful of cancers that can be diagnosed without liver biopsy. So the imaging has various characteristics that help us to make a diagnosis. And if I'm not mistaken, I think only renal cell carcinoma is the other cancer that can be diagnosed radiographically. So what we tend to look for on MRI or on CT scan is, mass lesion. There tends to be enhancement. So the lesion really lights up as blood is going through the liver. And so the lesion is getting its blood supply from the hepatic artery, which is why it lights up. For some, it tends to have a pseudocapsule or a thin rind. I think of it as, the skin of a lemon versus the skin of a grapefruit. That's what I mean by a thin rind there. And then you also want to see the contrast washing out as blood is transiting out of the liver. And so that's called venous washout. And if you've had a lesion that is small, that has grown at least 50% between your imaging studies, that would also suggest that hepatocellular carcinoma is the underlying etiology. But again, this constellation of radiographic symptoms is how we can certainly diagnose hepatocellular carcinoma. Of course, if there is a concern that maybe a mass lesion represents another type of cancer, a biopsy can certainly be performed in that setting.
Do we have any evidence that supports these monitoring practices in hepatocellular carcinoma?
So there was a great study that was presented a few years ago at the liver meeting by Shim and colleagues. And it very nicely illustrates the effectiveness of follow-up on HCC in regards to two aspects of care. And outcomes. So the first is receipt of curative therapies, and the second is liver cancer-related death. So this was a large cohort of patients with chronic hepatitis B infection, so over 400,000. Some patients underwent regular follow-up, and that was pretty loosely defined. They had to be followed by a physician during that period of time, and they didn't specifically look to see if patients had appropriate surveillance. It was just follow-up in the medical system. And regular follow-up increased the likelihood of being able to undergo curative therapies. So this could have been liver segmental resection. It could have been use of liver-directed therapies for the treatment of cancer. And there was also a reduction in risk of death. So a 44% reduction in risk of death over this study. And you can see from the different columns here, while regular follow-up was certainly most effective or impactful on the natural history here in these patients, even a regular follow-up, so some follow-up during the study period, was important in decreasing the risk of liver cancer death. I think that this particular study in a very large population demonstrates the importance and the value of follow-up, certainly in the setting of HCC. And I think it speaks to the fact that we have to think about working collaboratively to get patients appropriate follow-up. So if you actually look at this, only about 23% of the cohort received regular follow-up, and 19% received no follow-up at all. So I guess, my question is, since we need to involve everybody who is taking care of the patient, Lauren, what can pharmacists do to be sure that patients stay on track with their monitoring in the setting of chronic hepatitis B infection?
Kim, I think that that's a really great question. And I think that this may not be an area that many pharmacists have specifically thought they have a role in. So, I think we're going to throw out some ideas, but there's going to be lots of opportunity for discussion. So we'd love to hear your thoughts as well. The thoughts that we had about the role of the pharmacist is that, you may be able to identify patients who will require that HCC monitoring based on specific medications you're filling in their pharmacy. So certainly if you have a patient who's on chronic treatment for viral hepatitis B, that's relatively easy to identify if they're mono-infected, right? So you're looking for specific medications that you would use to treat that viral hepatitis B. Of course, if you tuned into our first module, you know that Hep B and HIV have similar transmission risk factors. So you could have a patient co-infected with HIV and hepatitis B, and because we have so many HIV preparations that contain our tenofovir salts, you might not know that they have hepatitis B because they're serving sort of a dual purpose. So they might be harder to identify, but your patients who are only receiving that tenofovir salt will be much easier to identify. The other thing that I think you could look for in terms of medication refills is you could look for specific medications used to treat the complications of cirrhosis. So I think a lot of these will probably jump out at you, even though there's medications that are in that class used for different disease states. There's specific medications we use for treatment of cirrhosis complications. So I'm not going to belabor these or give you any PTSD from when you were in pharmacy school and had to learn about them, but just to quickly highlight, certainly if you have a patient who has ascites, they could be receiving treatment with furosemide and spironolactone. You always see that dual combo in the ratio of 40 to 100. And we know that that's the specific ratio that's needed to maintain the normal kalemia. Certainly, we also have patients with cirrhosis develop hepatic encephalopathy, and then you're looking for your lactulose. And then certainly the other medication that you might think about is rifaximin. So it's our non-absorbable antibiotic that can be used to decrease the bacteria in the GI tract that produce ammonia. And there has been specific dosing approved for hepatic encephalopathy. Previously, it was that 400 Q8 that was used when we only had that 200 milligram capsule available. There is the 550 capsule that should be twice a day, and that's going to be what's used for our patients with hepatic encephalopathy. So then thinking about other potential complications, certainly variceal bleeding is something that these patients can experience. And, really you're looking for those non-selective beta blockers that are working at a specific location to decrease the blood flow to that portal vasculature to decrease your risk of bleeding. And when you're thinking about those non-selective beta blockers, there's actually not a ton. The two that you're probably most familiar with are nadolol and propranolol. If you see those, you can almost guarantee, unless you've got an older physician prescribing, that it's being used as variceal bleeding prevention, either primary or secondary prophylaxis. And then I think maybe the hardest in terms of identifying a specific medication is spontaneous bacterial peritonitis. It used to be that if you saw the fluoroquinolone, ciprofloxacin once weekly, you could know that they had an episode of SBP and were receiving prophylaxis against future episodes. Of course, now we know that intermittent antibiotic dosing leads to resistance, and so it's not recommended at this point.
We still use Cipro in addition to Bactrim, but as you pointed out, not at that once weekly dosing.
So the antibiotics are not quite as a slam dunk, but hopefully that gives you a little bit to think about in terms of what medications you might be seeing that would trigger you to think this is a patient who has cirrhosis and complications, and you might want to think about, talking with them about the importance of screening for hepatocellular carcinoma. I think that sometimes the more people hear the recommendations in different settings from different providers, the more it really sticks. And I think especially, I found if I go into a counseling session for a patient and I show them what I'm looking at and why I'm concerned, they're a lot more likely to engage in the conversation and to have a better, I think, understanding about how they can be an active participant in their healthcare. So hopefully we've given you some helpful clues about how you could potentially think about identifying these patients, and then thinking about talking to them about why it's important to screen for hepatocellular carcinoma in those high risk groups that we've talked about. Some tips you can use when you're thinking about counseling them. So you want to educate them about regular follow-up and monitoring for disease progression. And at a minimum, this should be every 6 months. You can talk to them about the long-term implications of chronic Hep B infection. So it's important they may not fully be aware of what can happen in terms of if they're not getting their disease under control and having follow-up at the risk of cirrhosis. And certainly I think not just cirrhosis, but talking about those complications that can develop is important to really help them fully understand the implications. And of course, hepatocellular carcinoma or liver cancer. You want to talk with them about making sure that when they see medical providers, that they make them aware of their hepatitis B surface antigen positivity status. It's important for all providers to be aware of this in terms of being able to best select treatment for cancers and immunologic conditions. We're going to talk about why this is so important in really this sort of second portion of our talk today. Certainly, in terms of alcohol use, it's important to counsel them about avoiding or limiting them, since we know that alcohol is also a hepatotoxin. So we want to decrease any additional stress on the liver by limiting alcohol use. And then in terms of body weight and addressing metabolic complications, I've mentioned briefly non-alcoholic fatty liver disease. So it's important, I think, in these patients to think about all of the potential things that could influence the risk of progression, and that certainly includes weight management and prevention of the risks of non-alcoholic fatty liver disease.
So thanks for those really helpful tips. Now we're going to discuss a topic that I would say is perhaps not as publicized, but just as important. And that's for healthcare providers to be mindful of reactivation hepatitis B. So there are new targeted treatments and biologics that have really revolutionized the treatment of patients with cancer, those with autoimmune diseases, and those requiring organ transplantation, such as stem cell transplants. But their use may be associated with reactivation. And depending on the mechanism of action of these immunosuppressing drugs, there's a differing level of risk of reactivation. We can certainly see hepatitis B reactivation in those patients who are co-infected with hepatitis C infection and being treated with direct-acting antivirals. So it's something to be mindful of in that situation as well. And it's pretty important, that we deal with these issues as patients are being considered for therapy. And that's for this immune suppressing therapy, because disruption of treatment can really have a profound effect on disease control and overall survival, depending on the indication for treatment. So with hepatitis B reactivation, the immune suppressing medication results in a loss of immune control of the virus. And then there's subsequently an increase in the hepatitis B DNA in someone with chronic infection or prior exposure. A hepatitis flare can then be experienced, which results in an elevated ALT. And some patients, while they may be asymptomatic, others will develop severe liver injury and could potentially go on to death. Regardless of the severity, the goal is really to prevent a flare so that the immunosuppressive treatment does not have to be delayed.
We need to talk a little bit about the definitions of hepatitis virus reactivation and a hepatitis flare. Now, I will tell you that if you go into the literature to take a look at studies related to hepatitis B virus reactivation, for quite a while it was not well defined. And so a lot of the studies looking at hepatitis B virus reactivation, there's a lot of heterogeneity in terms of how it was defined in these different studies. So more recently, some of our national and international liver associations have developed some specific definitions that have really, I think, allowed for a more cohesive discussion of these particular topics. So again, just to orient you to these organizations that you may or may not be familiar with. You're probably familiar with AASLD, but you may not be as familiar with the other two. So AASLD is the American Association for the Studies of Liver Disease. This is our US-based organization. The center column is EASL, or the European Association for Studies of Liver Disease. And you see that these are undefined criteria. So I'm not going to refer back to EASL much at this point. And then APASL is the Asian Pacific Association for the Study of Liver. So, and that's an organization that you may not be as familiar with. So I thought it was important to let you know what those organizations are. So AASLD defines a reactivation of hepatitis B as an elevation in the Hep B DNA compared with baseline, or an absolute increase if the baseline is unavailable. The other interesting component to that definition is it says seroconversion, but when I think about it, I almost think about it as reverse seroconversion, if you will. So when we talk about patients with hepatitis B, we think about them being positive for that hepatitis B surface antigen. That's our marker that they have an active infection. And so if they convert to be hepatitis B surface antigen negative, that's a marker that they've been able to clear the infection. But what you can effectively see is that they've cleared it and then they reactivate. So they become surface antigen negative and then become surface antigen positive. So it's almost like a reverse seroconversion is effectively how I've seen it described in the literature. In terms of APASL, their definition is a greater than 2 log increase from baseline in the levels of the hepatitis B DNA, or a new appearance of a hepatitis B DNA to a level of greater than or equal to 100,000 international units per milliliter in a person with previously stable or undetectable levels. And the second part is a detection of Hep B DNA level greater than or equal to 20,000 international units per milliliter in a person with no baseline Hep B DNA. So this is sort of nice. They give you information for someone that you have a level for, and then information on someone where you don't previously have a level 4. And I like this kind of specific definition to augment the AASLD definition. Moving on to the hepatitis flare, it's defined by AASLD as an ALT elevation greater than 3 times baseline levels and greater than 100 units per liter. APASL defines it as an intermittent elevation of seroaminotransferase levels to greater than 5 times the upper limit of normal and 2 times the baseline value. So I think it's important to kind of point out some of those differences. Certainly, we know that there's variability in patients' baseline values for these aminotransferase levels. There could be various reasons for that. So I think it's nice that they kind of have that additional definition of baseline as well as upper limit of normal, because certainly we have patients that at baseline have elevated levels. So it's nice to sort of have both of those in there. The other thing I wanted to point out sort of related to this definition is that the ALT generally rises before we have an increase in the Hep B DNA. And in my reading, it's suggested that the ALT is elevated about 2 to 3 weeks before you see that elevation in the Hep B DNA. So I think it's important when we think about Hep B reactivation, we're not just looking at evaluating the Hep B, but it's important to get a complete metabolic panel to really look at a comprehensive view of the liver. Kim, any other thoughts in terms of your clinical practice, in terms of what you've kind of seen related to reactivation or hepatitis flares in these specific lab values?
You do tend to see the ALT rise first. Some of the recommendations that I'm going to go over in those patients who have had prior infection, which is now resolved, there is a recommendation to not only check the hepatitis B DNA and some to check the hepatitis B surface antigen, but also to check that ALT every 1 to 3 months. And certainly a rise in the ALT is going to suggest that something is going on. And I agree, you'll tend to see the hepatitis B DNA rise thereafter. You know, perhaps it speaks to some replication that may be going on in the liver that may not be appreciated in the serum sample at the time that we're seeing the ALT rise. But regardless, I think it's important in clinical practice to make sure that people are also getting that metabolic profile to see what the ALT is. For those of you who have been following this series, if you've been looking at part 2, and I guess if you haven't looked at part 2, you should perhaps look at part 2, because we do talk about how the ALT has changed over time, and our threshold for determining whether an ALT is normal or not has changed over time. And I think that that's a very helpful discussion, certainly in the setting of hepatitis B. The thresholds that are now utilized by AASLD and other organizations include a ALT level of 19 for women and 30 for men. So anything over 25 would be abnormal for a woman. Anything over 35 would be abnormal for a man. So just something to think about as we're thinking about those normal ALT levels. So I'm going to just review the different recommendations from the societies that we have. And I think it really will help to focus people as they think about who might need to be placed on prophylactic therapy so that hepatitis B reactivation can be avoided. So regardless of the algorithm that one uses, the first step, and perhaps the most important step, is to screen for hepatitis B infection. And I think that this is a really, really important point. And we're now starting to see the specialists, our oncologists, our rheumatologists, our IBDologists who are getting ready to start their patients on therapy. They're now starting to screen for hepatitis B infection. And it's important to screen with either 2 or 3 serologies, the serologies that Lauren outlined. So we can see that all of the societies suggest screening. Screening should at least include sending a hepatitis B surface antigen and a core antibody, with EASL also suggesting that antibody to hepatitis B surface be sent as well. In clinical practice, I usually will evaluate patients for all 3. I actually think that evaluating a patient to determine whether they've been vaccinated is important, and certainly making sure that they receive vaccination if they're found to be susceptible is also an important part of the management here. For status, so hepatitis B status is really an important breaking point here when we talk about the algorithm for whether patients go on to prophylaxis or whether they will go on to monitoring only. And you can see each of the societies uses chronic hepatitis B infection versus resolved infection. So chronic hepatitis B would be those patients with a hep B surface antigen that's positive. Those with resolved infection would have a negative hepatitis B surface antigen, but a core antibody. And you can see with all patients with chronic hepatitis B infection, they should be started on prophylactic therapy. We'll talk about that in a second. Lauren mentioned this earlier in the talk. Really important to do that because the risk of reactivation in patients with chronic hepatitis B infection is so much higher than it is in those with resolved infection. We see also those patients with resolved hepatitis B infection who are going to be treated with what we consider high-risk therapies. So those therapies that are associated with the highest risk of hepatitis B reactivation. And primarily we're looking at agents like rituximab or organ transplant states such as stem cell transplant. All of those patients, I should say, essentially all of those patients would go on to prophylaxis here. We can see the apostle recommendations kind of diverging here, where it says rituximab in lymphoma, either prophylaxis or monitoring, and they're calling for further studies, but certainly what I do in clinical practice, because I think that the risk is so high with rituximab, is that I will put those patients on prophylaxis before starting. The area where there is some divergence in recommendations is really the group of patients with resolved hepatitis B infection who are going on other therapies. Therapies that are of moderate risk for reactivation or low risk for reactivation. And so this could include anti-TNF therapy, high-dose steroids, et cetera, where some of the societies are recommending either prophylaxis or on-demand therapy where you're monitoring every 1 to 3 months with at least ALT and the hepatitis B DNA. Apostle recommendations suggest that you check for a hepatitis B DNA in those patients with resolved hepatitis B infection. And if they have any detectable level of hepatitis B DNA, starting on prophylactic therapy. So what do we use for prophylactic therapy? We use high potency agents that are associated with very little resistance. And so our choices include entecavir, tenofovir, this is the disopropyl fumarate preparation, and then TAF is the alafenamide preparation. The TAF version of this for those patients with some degree of renal dysfunction or perhaps some degree of bone disease. But those are the 3 agents that I choose from when I'm thinking about prophylactic therapy. I will place patients on these medications and continue at least until they are off of their immune suppressing regimen for 12 months. You can see some of the societies, so specifically EASL, suggesting that patients who are on rituximab should continue to get prophylactic therapy up to 18 months after they discontinue their rituximab, including immune suppressing regimen. And then for patients, we'll tend to suggest follow-up after that. So even after that 12 to 18 months after they've been off of therapy, continuing to monitor them. So while I think that there is divergence here in some of the recommendations, I think it's always more important to err on the side of caution. And if you're concerned that a patient is at increased risk of reactivation, that you use prophylactic therapy. So with that, let's summarize our discussion with SMART goals. So specific, measurable, attainable, relevant, and timely. That's, of course, what we hope that you will take away from this talk today. And so our SMART goals are the following. With each hepatitis B medication refill, that we seize an opportunity to educate patients about hepatocellular carcinoma, that we ask about regular monitoring and surveillance for HCC, that we heighten awareness for hepatitis B reactivation and query patients receiving immune suppressing therapy about regular monitoring by their healthcare providers. And lastly, that we advise patients to inform all current and future medical providers of their hepatitis B surface antigen positive status, especially if they ever need treatment for cancers or other immune disorders. So Lauren, with that, I think it's time for us to let our audience join the conversation and ask some questions. So good morning, and thanks for joining us for the Q&A session this morning. We already have a number of questions in the chat box, so let's dive right in. So Lauren, I'm gonna have you answer one of the questions in the chat box here. And the question is, what is a way that you counsel patients on coexisting metabolic complications that need to be addressed to prevent fatty liver disease and further impact on the liver? And so I'm interested to hear the pharmacy perspective on this. So I'm not hearing Lauren at the moment. So I'm going to go ahead and answer this question, and we'll try and get her audio online. So with all my patients in the clinic, we actually have a discussion about metabolic complications. Some of the things that I suggest to patients: maintaining a healthy weight, making sure that they're consuming a healthy diet, and making sure that those metabolic complications, including diabetes, hypertension, hyperlipidemia, are well controlled in conjunction with recommendations that are being provided by their primary care physicians. So I actually think that I hear Lauren on the line now. I'm going to see if she can go ahead and give us her thoughts on this issue.
Sorry, Dr. Ford, can you hear me now?
I can hear you. That's fabulous.
Okay, I think my microphone was on vacation. So I heard some of the answer that you provided in terms of healthy weight and eating healthy, and I absolutely would echo that. I think that there are probably a lot of patients with metabolic complications that are under-recognized. So this is, I think, incredibly important to address with our patients. I do think that one of my strategies is to try to make it manageable for patients. So identifying maybe just one thing at a time that I can change or have them change, and really having them help in identifying what those small changes are. So I had one person drinking, I think, a liter of grape soda a day. And so we talked about, could you make that liter of grape soda last a week or a couple of days? Or how could we slowly kind of, wean back on that amount of soda? So really trying to, I think, dig into things that are really going to make the biggest impact in those metabolic complications, and recognizing that it's hard work. So I sometimes say to my patients, sometimes hard work is required. I learned that from my yoga teacher. So, I think that we have to recognize, and patients have to recognize, I think, especially as pharmacists, when we're the medicine people, right? And you can't always just hand someone a pill and fix it. There's so much related to our health where hard work is required. And this is particularly relevant, I think, as it relates to the metabolic complications.
Hey, I think that that's great. The other thing that I would echo is that very small changes can make a very large impact. Patients have told me they've stopped drinking soda and they immediately started to lose weight. They stopped drinking their calories, so they changed what they were drinking to water primarily, and would eat their calories rather than drinking them, and that makes a big impact as well. And so in the office, I will also suggest some nutrition counseling. There's certainly counseling that can be obtained online, counseling that can be provided in the office, and counseling that can be provided by a nutritionist if covered by insurance as well. And so I think all of those strategies are very helpful. But again, it's the small changes that can overall impact on health globally that we're really trying to influence here. So going back to the chat, there's one question, actually two questions. One about the preference between the TDF preparation of tenofovir and the TAF preparation of tenofovir. Well, certainly if I could use the TAF preparation, I would. Sometimes I am limited by, number one, what's on formulary if this is a patient who is hospitalized. Number two, I'm often limited by the insurance and what they're going to cover as far as the provision of one formulation over another. TAF is certainly associated with less in the way of long-term renal dysfunction and bone issues. And so if I could, I would recommend TAF, but I certainly can't do that in all scenarios. There's another question regarding when I depart from the recommended frequency of monitoring in the guidelines that are provided regarding hepatitis B reactivation. And I would say if I'm concerned about a patient or I'm starting to see an ALT that's rising, I will certainly monitor more frequently. And so I certainly diverge there. Going back to the chat, so there's a question about rituximab being one of the biggest culprits for reactivation, and do I look at all immunosuppressants with the same lens? And I certainly don't. Some of the societies have even recommended hepatitis B reactivation prophylaxis in the setting of high dose steroids, which I have not seen reactivation in that setting, and I usually don't prescribe prophylactic therapy in that setting. I would say chemotherapeutic agents are certainly of concern. I would say that the anti-TNFs, there's some data emerging, but again, the risk is really intermediate in that case. I would say that rituximab and regimens given around stem cell transplant happen to be in the highest risk for reactivation. So certainly those patients need prophylactic therapy. All right, going back to the chat here. So this is a question for Dr. Heineke. So how can pharmacists reassure patients that routine monitoring should not take much time and stress the significance of monitoring and hepatitis B reactivation at the same time? So I wonder if you have some specific strategies that you utilize with your patients.
So I think the first part is a little hard in terms of won't take much time. I think it's hard to guarantee that. And we've all been to the doctor's office and gotten there well before our appointment and been there well after our appointment. So, I think it's not so much about the time. I mean, it is not something that we're asking people to go in and do even on a monthly basis. So it's not a frequent monitoring, but it may be that they go in and they might be there for a bit of time. But I think it's important to stress the importance of what it could prevent going forward, the complications, and how severe those complications could be if they don't have that monitoring done. So I don't know if I would stress that it's not going to take a lot of time, but that in the scheme of life things, that this is something that's going to help them have a higher quality of life, to make sure that they don't end up with those really severe complications, liver cancer, which is certainly going to be a very time-intensive treatment process. So I think it's about really explaining, I think, some of those complications and consequences if it's not caught early, and probably things that people aren't necessarily as familiar with. It's not like hypertension and diabetes, which most people could quote you the complications that would develop. So I think that's sort of the angle that I would take, and really the time factor, thinking about, if you do develop these complications, these are going to be the implications, would be my strategy.
So in my clinical practice, I try to tether the performance of labs with some other healthcare maintenance activity. So if it's in my patients with chronic hepatitis B and they have to get an ultrasound for HCC surveillance, I'll tell them, well, you can come in and you can get the labs on the same day that you're getting the ultrasound. So you're actually able to conduct both of the pieces that are necessary for that surveillance piece. The same is true for those patients who are being monitored for reactivation. So again, tethering it with another part of their healthcare, if they have to come in and get blood work for their infusions, we'll just make the hepatitis B reactivation labs part of that blood work for their transfusion blood draw. So again, I think tethering helps to decrease the time that patients are actually coming back and forth from the lab, or coming back and forth from the hospital or the radiology center, so that you can actually make sure that everything is done. And we are hopefully decreasing some of the time that's required to come in and out for various visits. There is a question about how we can address racial and ethnic disparities in the incidence of HCC. And from a clinical standpoint, I would say that many patients with chronic hepatitis B don't know that hepatitis B in and of itself is a risk factor for HCC. So I think reinforcing that information, also letting patients know that early liver cancer has absolutely no symptoms. We have to look for these cancers on ultrasound. And without that ultrasound, I will not be able to tell them if there's something there. Likewise, because of the doubling time of the tumor, that 6-month recommendation for follow-up imaging has been put into place. So I think it's important to just emphasize why the testing is required, how frequently the testing needs to be done, and again, trying to empower patients with some of this information. And hopefully they too will pass it on to their doctors. Certainly, the patient doesn't have to come to the specialist to get some of this testing done. They can get it done with their primary care providers. And I think reinforcing that at a pharmacy level is very helpful. If you see patients who are filling hepatitis B medications, entecavir, tenofovir of some version, and saying, oh, have you been to your healthcare provider? Have you gotten your HCC surveillance done? I think all of those prompts are very helpful. And again, if we're doing this across the board, I certainly think that we will increase the number of patients who are getting screened for liver cancer, and also the number of patients who are being diagnosed and subsequently treated. Dr. Heinecke, I don't know if you have other strategies you employ at the time of medication fills to kind of remind patients about getting surveillance.
I mean, I think it's important to understand the population that you're serving. So, really getting to know who's in the community where your pharmacy is and where you're working, I think is really important to better understand how you can make an impact. And I think starting with a CE like this, and now if you weren't aware of some of those racial and ethnic, disparities related to hepatitis B and HCC, now you are. And if you're in a population where maybe it would be more likely that you would see more hepatitis B and HCC, finding ways to work with the community, to partner with the community to make an impact. We're going into a little bit of kind of community engagement, and I think so often we want to go in and be helpful, but don't fully understand how to do that without having conversations with members of the community. So now I'm getting a little bit on my soapbox and getting off topic, but definitely understanding the community that you're working with and finding those ways if you think that there might be some hepatitis B and HCC that you could really impact related to the population.
So actually, I think that that's a great segue into another question that was asked about non-English resources. So there are certain community partners. There are foundations like the Hepatitis B Foundation, American Liver Foundation. Some of those sources have materials that are in alternative languages. And I would say we have to do a better job, certainly, of providing those materials as well. But I do think that there are resources out there that are helpful to patients and in other languages if English is not a first language for your patient. Dr. Heineke, have you used other resources online that are helpful, certainly to patients and perhaps in other languages?
So within our electronic health record, we have access to UpToDate and Lexicomp, which is a lot of medication information, and that allows you to choose the medication information in, I don't even know how many languages. It's a lot. So if you're looking for specifically medication information and you're working with Epic in a hospital setting, or you're in the community setting and you have access to those Lexicomp UpToDate education materials, I think those are helpful. I think the CDC often has education materials, definitely in Spanish. I think there's some other languages as well, but I agree, Dr. Ford. I think we probably need to we could do a better job at providing additional education in other languages.
So unfortunately, that brings us to the end of our time today. We've had many great questions. I'm so sorry that we're unable to get to all of them today. But before we go, let me remind you of the key points or SMART goals from our program. They are to, with each hepatitis B medication refill, seize opportunities to educate patients about HCC, ask about regular monitoring and surveillance for HCC, heighten awareness of hepatitis B reactivation, and query patients receiving immunosuppression about regular monitoring by their healthcare providers. Advise patients to inform all current and future medication providers of their hepatitis B surface antigen positive status, especially if they ever need treatment for cancer or other immune disorders. Thank you, our audience, for all the great questions you sent in. For additional clinician and patient resources and additional opportunities for live credit across a variety of therapeutic areas, please visit CMEO Pharmacist Central at cmeoutfitters.com. Don't forget to complete the post-test and evaluation for today's program. Stay safe, and thank you again for participating and for providing the best care for our patients. Thank you. Bye-bye now.